Hello friends, welcome to my YouTube channel. Now I am studying community medicine, starting with healthcare of the community. The goal is the ultimate desired state towards which objectives and resources are directed. It is long term and not constrained by time or resources. The plan is the blueprint for taking action in order to achieve the goal. Target refers to the quantifiable and achievable midterm endpoints in the plan. Mission describes the cause of the existence of the program. The objectives are short term endpoints. They are precise points in the plan. They are either achieved or unachieved. Procedure is a set of rules for carrying out work. It helps to ensure the maximum use of resources and efforts. Program is a sequence of activities designed to implement policies and accomplish objectives. Schedule is a time sequence for the work to be done. Next is a case. A team of doctors is planning to conduct a survey on the prevalence of infective diarrhea in a village. The correct sequence of steps involved in the planning of this activity is: first is analysis of the health situation, next is establishment of objectives and goals, next is assessment of resources, and finally fixing priorities. The planning cycle includes the following steps, which include analysis of the health situation, establishment of objectives and goals, assessment of resources, fixing priorities, writing up of a formulated plan, programming and implementation, monitoring, evaluation. Repeatability is not a component of the evaluation of health programs. Components of evaluation are relevance, adequacy, accessibility, acceptability, effectiveness, efficiency, effect or impact. The steps of evaluation of a health program are: determine what is to be evaluated, that is, structure, process, or outcome, establish standards and criteria, plan the methodology to be applied, gather information, analyze the results, take action, and finally re-evaluate. Management by objective is based on behavioral sciences. Management methods used in health programs are either quantitative or based on behavioral sciences. Methods based on behavioral sciences include organizational design, personnel management, communication, information systems, management by objectives. Quantitative methods include cost benefit analysis, cost effective analysis, cost accounting, input output analysis, model, systems analysis, network analysis, which include program evaluation and review technique, and critical path method, planning, programming, budgeting system, work sampling, and decision making. These all are quantitative methods. Cost benefit analysis is a quantitative method of management. In this method, the economic benefits of any program are compared with the cost incurred. The benefit of the program is expressed in monetary units. The main drawback here is that the benefits of a health program cannot always be expressed in monetary terms. In detail about cost effective analysis, cost is measured in health units, outcome measured in natural units like life years gained, cases prevented, etc. Most comprehensive indicator is quality adjusted life years, that is QALYS, QALYS. Uses of cost effective analysis include evaluation of activities under a program and comparing clinical strategies to deliver the same. In detail about the cost benefit analysis, cost is measured in monetary units, outcome measured in monetary gain. Uses of cost benefit analysis include at executive level of government, example budgeting, etc. In cost effective analysis, benefits are measured in natural units of the outcomes of the program. The program evaluation and review technique, that is PERT, is used for network analysis. It is a type of quantitative management technique which helps in detailed planning and comprehensive supervision. Network analysis in health management is: a network is a graphic plan of all events and activities to be completed in order to reach an end objective. Two types of network analysis include PERT and CPM. PERT is Program Evaluation and Review Technique. An arrow diagram of all events in logical sequence is drawn. Time to finish each activity can be calculated and critical activities can be identified. It aids in planning, scheduling, and monitoring of the project. Next is CPM, that is critical path method. It is the longest path of the network, which is known as critical path. A delay in the critical path will cause a delay in the entire project. In the zero-based budgeting approach, that is ZBB, the budget for each new period is created starting from a zero base. It does not rely on the data from the previous budget. It is a quantitative method of management. Detail about traditional budgeting. Previous year's budget is used as a template. Only new expenses are need to be justified. Traditional budgeting is used to study changes in expenditure. Activities are directed towards monitoring of expenditure. In detail about zero-based budgeting, it starts from zero base with newly set targets followed by priority-based allocation of resources, that is target to resource. Each expense needs to be justified, both old and recurring expenses. Zero-based budgeting is used to study the cost-benefit analysis. Activities are directed towards achievements of objectives in zero-based budgeting. Next is a case. A hospital administrator is systematically recording the activities of his team at regular intervals. In this case, work sampling is a systematic observation and recording of activities of one or more individuals carried out at a regular or random intervals. It is a type of quantitative method of management. It helps in standardizing the methods of performing the jobs and determining the need for manpower. The High Level Expert Group, that is HLEG, on universal health coverage under the aegis of the Planning Commission of India suggested a 3.5-year bachelor degree course in medical education for rural health services. This was planned for the 12th 5-year plan, that is 2012 to 2017. The degree given was BSc Community Health, and these rural health care practitioners were to be called Community Health Officers. International Universal Health Coverage Day is observed annually on December 12th. Sir Joseph William Bohr was appointed as the chairman of the Health Survey and Development Committee in 1943. This committee was hence named Bohr Committee. The 3 million plan was proposed by the Bohr Committee. It proposed to set up the following in the long term, that is primary health units with 75 bedded hospitals for each 10,000 to 20,000 population, secondary units with 650 beds, district hospitals with 2,500 beds. As a short-term measure, it was proposed that each PHC must cater to 40,000 people and have 2 medical officers, 4 public health nurses, 1 nurse, 4 midwives, 4 dais, 2 sanitary inspectors, 2 health assistants, 1 pharmacist, and 15 other class 4 employees. Comprehensive healthcare, as stated by the Bohr Committee, means giving integrated preventive, curative, and promotional healthcare to every individual, irrespective of their ability to pay. VED is a method of inventory management used mainly in drugstores and pharmacies. The drugs are classified in 3 categories as follows: V for vital drugs, E for essential drugs, D for desirable drugs. V for vital drugs, items whose absence cannot be tolerated, that is 10% of the total items are vital drugs. Next is E for essential drugs, that is items whose absence can be tolerated for some time, that is 40% of total items are essential drugs. Next is D for desirable drugs, items whose absence can be tolerated for a long time, that is 50% of total items are desirable drugs. ABC analysis, that is ABC, always better control. Always better control analysis refers to a type of inventory management in which items are divided into 3 categories according to their cost. This type of analysis aims to calculate expenditures of large proportions on a small number of items and vice versa. It makes it easier to understand how to control the majority of expenditure by analyzing the small numbers of items it is being spent on. Other types of inventory management are FSN, that is fast, slow, non-moving drugs. In ABC analysis, the items are categories into A, B, C categories based on total cost usage. VED is vital, essential, desirable drugs. HML is high cost, medium cost, low cost drugs. In HML analysis, the items are categorized into HML category based on unit cost. So, other types of inventory management is FSN, VED and HML. National Health Policy 2017 aims to increase the public health expenditure from existing 1.15% to 2.5% of the GDP by 2025. The draft of the policy from 2015 was passed by the government in 2017 and it is called the National Health Policy 2017. The right to life is given in Article 21 of the Indian Constitution. Article 11 defines the right of the Parliament to regulate the right of citizenship by law. Article 23 defines the prohibition of traffic in human beings and forced labor. Article 25 defines the freedom of conscience and free profession, practice and propagation of religion. Adulteration of food is included under the concurrent list. The legislative section of the 7th schedule is divided into 3 lists, that is Union list, State list and concurrent list. Union list is a list of 100 items on which the Parliament has exclusive power to legislate. State list is a list of 61 items on which the state government has exclusive power to legislate. Concurrent list is a list of 52 items on which both central and state governments have the power to legislate. First referral unit and non-first referral unit belong to the community health centers, that is FRU and NFRU belongs to community health centers. The Indian Public Health Standards Guidelines are a code of standards for uniformity in health facilities in the Indian public health system under the National Health Mission, Ministry of Health and Family Welfare, India. It aims to provide guidance on the infrastructure, human resources, drugs, diagnostics, equipment, quality and governance requirements for delivering health services at all levels of facilities in the system. The 2022 edition of IPHS mainly concentrates on comprehensive primary health care, increasing the human workforce, decentralized access to health care, and better implementation of universal health coverage. Levels of health care system in India are primary level, secondary level, and tertiary level. Primary level includes primary health centers, sub-centers, ANM, ASHA, VHG, AWW, trained DAIs. Next is secondary level, which includes district hospitals, sub-district hospitals and community health centers. Tertiary level includes regional specialized hospitals and medical colleges. Elements of primary health care include code is elements, ELEMENTS. E for education about health problems and their prevention and control. L for locally endemic diseases, that means prevention and control of locally endemic diseases. E for essential drugs. M for maternal and child health care. E for expanded program of immunization against vaccine preventable diseases. N for nutrition and proper food supply. T for treatment of common diseases and injuries. S for safe water and sanitation. Principles or pillars of primary health care include equitable distribution, community participation, intersectoral coordination, appropriate technology. In a district having a population of 20 lakhs, the number of beds the district public health system should have is given as follows, that is 2000 essential and 4000 desirable. According to IPHS 2022 norms for the number of beds in district hospitals, 1 bed per 1000 population is essential and 2 beds per 1000 population would be desirable. Therefore, in a population of 20 lakhs, the district public health system should have 2000 essential and 4000 desirable beds. The essential number of beds should be achieved through the public health system of tertiary care like medical colleges, secondary care like district hospitals, sub-district hospitals and CHCs, and primary care in the district like PHCs and CHCs. According to IPHS 2022 guidelines, a minimum number of 50 essential beds, that is 50 essential beds would be required for a district with a population of less than 2 lakhs. Every district should have at least one comprehensively functioning district hospital. District hospitals and sub-district hospitals provide secondary care health services. Every district should have at least one comprehensively functioning DH. Districts with a population of less than 5 lakhs and with a functional DH do not need a sub-district hospital. Districts with a population of 5 to 10 lakh can have one sub-district hospital. For a population of more than 10 lakhs, one sub-district hospital is needed for every 10 lakh population. The three pillars of district hospital services are providing clinical care, providing a knowledge hub for capacity development, and public health programs. Important functions of district hospitals are providing curative services, palliative and rehabilitative services, implementation of health programs, drugs and diagnostic services, administrative and other supportive services, health promotion and prevention, and also education, providing educational services like Diplomate of National Board training, training courses for healthcare professionals in auxiliary nursing and midwifery, telemedicine and technology, and partnerships with universities. First, referral unit community health centers can be located in rural areas. Community health centers can be classified into following types, that is non-FRU CHC and FRU CHCs. Non-FRU CHCs are located in rural areas. They provide preventive, promotive, palliative and rehabilitative services. They also have curative services for normal delivery, stabilization of common emergencies, etc. FRU CHCs are the first centers of referral from smaller centers such as sub-centers or primary health centers. They can be located in rural as well as urban areas. Apart from providing the above mentioned essential services, they also provide specialized services and elective surgeries. All the CHCs located in urban areas are FRU CHCs. In addition to the above centers, CHCs called block health public units may be located in the block headquarters. Apart from clinical and public health services, they have a health management information systems. They also help in decentralizing health services. The number of essential beds in a non-first referral unit CHC is 30. The number of beds in district norm is 1 bed per 1000 population. In FRU urban CHCs, bed count is 50 beds. In rural FRU CHCs, 30 beds. In non-FRU CHCs, 30 beds. In 24 into 7 HWC PHC or UPHC, 6 beds. In polyclinic, 2 daycare beds. In HWC UPHC, that is Health and Wellness Center, Urban Primary Health Center, there is 2 daycare beds. In HWC PHC, there is 2 beds. A rural hilly area with a population of 40,000 should have 2 primary health centers. According to the latest IPHS 2022 guidelines, in hilly areas there should be 1 PHC for every 20,000 population. Since this village has a population of 40,000, it should have 2 PHCs. HWC PHC has a population norm like in hilly or tribal area there is 1 per 20,000 population. In plain areas there is 1 per 30,000 population. Next is in urban HWC UPHC population norm is 1 for every 50,000 population. Next is specialist UPHC or polyclinic. It serves a population of 2.5 to 3 lakhs covering a catchment population of 5 to 6 UPHCs. The 12 packages envisaged under comprehensive primary healthcare services are care in pregnancy and childbirth, neonatal and infant healthcare services, childhood and adolescent healthcare services, family planning, contraceptive services and other reproductive healthcare services, management of communicable diseases through national health programs, general outpatient care for acute simple illness and minor ailments, screening, prevention, control and management of non-communicable diseases, care for common ophthalmic and ENT problems, basic oral health care, elderly and palliative health care services, emergency medical services including burns and trauma, screening and basic management of mental health ailments. These all are the 12 packages envisaged under comprehensive primary health care service. Cholecystectomy is not a surgical procedure that is conducted in PHC. The surgical procedures done in PHC include suturing of wounds, incision and drainage of abscesses, vasectomy, tubectomy, and hydrocoelectomy. Services provided under PHC are general services like OPD, teleconsultation services, emergency services, 24/7 labor rooms, antenatal clinics, non-communicable diseases clinics, rotational specialist clinics, surgical procedures like suturing of wounds, incision and drainage of abscesses, vasectomy, tubectomy, hydrocoelectomy in PHCs with a functional minor OT and standard infection prevention protocols. Next is antenatal care and services like detecting pregnancy, provision of ANC and counseling services, identification, management and referral of high-risk pregnancies, detection of alarming signs during pregnancy and labor with timely and appropriate referral, monitoring high-risk pregnancies, management of malaria for pregnant women as per National Center Vector-Borne Disease Control Guidelines, management of tuberculosis during pregnancy, management of mild or moderate anemia, management of gestational diabetes mellitus as per Government of India guidelines. These all are the services provided under PHC. In a place with population of 10,000, 5 ASHA workers are needed. Functions of HWCs under sub-health centers are provide primary care services, deliver 12 packages under CPHC, serve as a platform for teleconsultation and widening the range of diagnostics, serve as a fulcrum for services in national health programs. Next is suggested norms for health workforce are doctor in 1 per 1000 population, health worker that is male and female that is 1 per 5000 in plain area and 1 per 3000 in remote or hilly area, health assistant male and female that is 1 per 30,000 in plains, 1 per 20,000 in remote or hilly areas. Next is a pharmacist that is 1 per 10,000, lab technician 1 per 10,000, auxiliary nurse midwife 1 per 10,000, urban social health activist that is 1 per 1000 to 2500, ASHA worker 1 per 1000 that is in a village area where there is 200 to 500 households 1 per 1000, 1 per habitation in remote or hilly areas. Trained dais or trained birth attendant is 1 per 1000 in a village area, village health guide that is 1 per 1000 in a village, Anganwadi worker 1 per 400 to 800 in plains and 1 per 300 to 800 in remote or hilly areas. Nurse is 1 per 5000. Mahila Arogya Samiti is 1 per 250 to 500 that is in a region where there is 50 to 100 households. Next is ASHA. ASHA stands for Accredited Social Health Activist. Must be a woman in the age group of 25 to 45 years, married or divorced or widow, must be a resident of that village, formal education of up to 10th standard. If no candidates are available, the requirement can be relaxed up to 8th standard. At least one ASHA for a population of 1000. In tribal, hilly and desert areas, the norm can be relaxed to one ASHA per habitation. Next is responsibilities of ASHA. Health education and awareness, reproductive and child health and family planning, facilitate the access to health services, promotion of sanitation and household toilet construction, provision of primary medical care for minor ailments, provider of DOTS, depot holder of essentials like ORS, iron and folic acid tablets, condoms, disposable delivery kits, etc. Disposal of health information on her community to higher centers. Some responsibilities are integrated with Anganwadi workers and auxiliary nurse midwife. Home visits by ASHA under home-based newborn care is 7 visits after home delivery that is on day 1, 3, 7, 14, 21, 28 and 42. 6 visits after institutional delivery that is on days 3, 7, 14, 21, 28 and 42 in case of vaginal delivery and 5 visits in case of cesarean section delivery where the mother returns home after 5 to 6 days that is on days 7, 14, 21, 28 and 42. Home visits by Asha under home-based care of young child is a total of 5 visits are scheduled after 42 days under the home-based care of the young child. Asha will provide quarterly home visits on the 3rd, 6th, 9th, 12th and 15th months. Specialists like ophthalmologists are not included as essential manpower for a PHC. Specialists for medicine, obstetrics and gynecology, pediatrics, ophthalmology, etc. are essential manpower included under polyclinics. According to Indian Public Health Standard 2022 guidelines, a total of 12 staff is considered essential manpower for a PHC. They include 1 medical officer, that is MBBS doctor, 2 staff nurses, 1 pharmacist, 1 health worker female or auxiliary nurse midwife, 1 health worker or health assistant which is male, 1 health assistant that is female or lady health visitor, 1 laboratory technician, 1 data entry operator, 1 dresser, 1 accountant and 1 sanitation staff. Responsibilities of female health worker is maternal and child health services, family planning services and registers, medical termination of pregnancy, universal immunization program, detection of non-communicable diseases, DAI training, treatment of minor ailments, participate in team activities. Responsibilities of male health worker include national health programs, malaria slides and surveillance, leprosy follow-up, identification and follow-up cases of blindness, reproductive and child health services, RNTCP, expanded immunization program, environmental sanitation including chlorination of water and proper waste disposal. Next is responsibilities of health workers in common is nutrition, distribution of contraceptives, work on communicable diseases like DOTS and activities, record and report vital events, record keeping and maintain registers. Medical colleges are included in the tertiary level of healthcare system, which is also the second referral center. Providing physical rehabilitation is not an element of primary health care. Primary health centers are only responsible for the popularization and mainstreaming of PMR in the community. Primary health care refers to essential health care made universally available to individuals and acceptable to them through their full participation and at a cost the community and country can afford. Principles or pillars of primary health care include equitable distribution, community participation, intersectoral coordination, and appropriate technology. Accredited social health activists, that is ASHA worker, do not need to procure supplies from CHCs. They only act as depot holders for certain essential supplies so that they are readily available to their community. These essential supplies may include ORS, contraceptives, iron folic acid tablets, chloroquine, disposable delivery kits, oral contraceptive pills, condoms, etc. The norm is 1 Anganwadi worker per 400 to 800 population. Anganwadi workers are allotted under the Integrated Child Development Services. Anganwadi workers are selected from the community they are to serve and act as link between the community and health services. They are mostly part-time workers. Responsibilities of an Anganwadi worker include nutrition, health education, non-formal school education, referral services, health checkups and growth chart maintenance, counsel women on birth preparedness, importance of safe delivery, immunization and contraception, and prevention of common infections including STD and RTIs. 1 male and female health assistant are required for a population of 30,000 in plain areas and 20,000 in hilly or remote areas. USHA workers, that is Urban Social Health Activist, that is USHA, USHA. USHA workers cover a population of 1000 to 2500. She must be a woman who resides in the urban slums, preferably of age 25 to 45 years. This was a provision given by the National Urban Health Mission, which was passed by the Cabinet in 2013. 1 Mahila Arogya Samiti member is appointed for a population of 250 to 500, covering about 50 to 100 households. The duties of a male health worker include chlorination of water bodies, distribution of conventional contraceptives and reproductive and child health services, maintenance of eligible couple register, that is a part of family planning activities, and immunization are duties of female health workers. Health workers, that is male and female, are 1 per 5,000 in plains and 1 per 3,000 in remote or hilly areas. Malaria surveillance activities in accordance with the National Vector-Borne Disease Control Program are the duty of a male health worker. Trained birth attendants or dais provide medical services during delivery and in the postpartum period. They cater to a population of 1,000 in villages. Antenatal support is provided by the following, like health workers, that is male and female, 1 per 5,000 in plains and 1 per 3,000 in hilly or remote areas. Health assistants, that is male and female, 1 per 30,000 in plains and 1 per 20,000 in remote or hilly areas. Anganwadi workers, 1 per 400 to 800 in plains and 1 per 300 to 800 in hilly or remote areas. A subcenter caters to a population of 5,000 in general areas and 3,000 in hilly or remote areas. Services provided at subcenters are maternal and child health, family planning, counseling for abortion and adolescent health care, water quality monitoring and sanitation promotion, assistance to school health services, field visits and treating minor ailments, training of ASHA and birth attendants, disease surveillance and national health program functions. 2 female health workers are to be at subcenter as proposed by the Indian Public Health Standards. There are 2 types of subcenters, Type A and Type B. Type A has all facilities except for conducting deliveries. It can be upgraded to Type B. Type B is also called MCH subcenters. It has delivery facilities. As a medical officer of PHC, you would be responsible for mainstreaming Ayush and PMR, performing selected surgical procedures, collection and recording of vital events. Formal education is not a function of primary health centers in India. A radiographer is not a part of the manpower at PHC. They are present in CHCs. Accountants cum data entry operators, health educators and clerks are appointed at PHCs. The minimum number of beds in a PHC is 6. Each community health center covers a population of 80,000 to 1,20,000. Services provided by CHC include care of routine and emergency cases in medicine and surgery, maternal, newborn and child health, family planning, all the functions of national health programs, physical medicine and rehabilitation, oral health, school and adolescent health services, blood storage facility, diagnostic services, referral services, and maternal death review. The minimum number of beds in a CHC is 30, that is 30. One ophthalmologist is recommended by the IPHS for 5 CHCs. An urban CHC caters to a population of 5 lakh in a metropolitan city and 2.5 lakh in other cities. An urban PHC caters to a population of 50,000. An urban primary health center will cover 50,000 to 60,000 population and will be staffed with 2 doctors, that is 1 regular and 1 on a part-time basis, 3 staff nurses, 1 pharmacist, 1 lab technician, 1 lady health visitor, 4 to 5 ANMs, that is depending upon the population covered, other clerical and support staff and 1 program manager. Basic functions provided are OPD, basic lab diagnosis, drug or contraceptive dispensing, health education along with referral services. The principal unit of administration in India is the district under a collector. Under districts are the subdivisions, tehsils or talukas, municipalities or corporations, villages, panchayats, etc. As of 2021, there are 748 districts in India. The Panchayat Samiti or Janpada Panchayat operates at the block level. Panchayati Raj is a 3-tier structure of rural self-government in India. It operates at the following levels, that is Panchayat at the village level includes Gram Sabha, Gram Panchayat and Nyaya Panchayat. Panchayat Samiti or Janapada Panchayat at the block level and Zilla Parishad at the district level. So, the Panchayati Raj is a 3-tier structure of the rural self-government in India. It operates at the following levels, that is Panchayat at the village level, Panchayat Samiti or Janpada Panchayat at block level and Zilla Parishad at the district level. Village health guides are selected by the medical officer in charge. 2 to 3 candidates are put forward by the community for the position of village health guide. The medical officer selects one of them after consultation with the block development officer and field staff. Village health guides are chosen by the medical officer in charge, including PHCMO. Age is not a criteria for selection. The village health guide scheme was introduced in 1977. Guidelines for choosing a village health guide include: they can be of either sex but must be residents of the village. They must know to read and write and have education up to 6th grade. They must be able to spare around 2 to 3 hours a day for community work. They must be acceptable to all parts of the community. Village health guides are trained for 2 to 3 months before beginning work. The norm is to have one village health guide per 1,000 population. Next, I am going to talk about mental health. Mental health is a state of well being in which an individual realizes his or her own abilities and not merely the absence of mental illness. It is the ability to cope with stress, be productive, and contribute to the community. Mental disorders are universal and are not specific to any particular group. They are associated with hereditary, that is, family history of psychiatric disorders, and environmental factors. Substance abuse and alcohol addiction are considered types of mental illness. Economic insecurity, anxiety, and frustration are the socio-pathological factors associated with mental health. The factors leading to mental health illness include organic, that is, cerebral arteriosclerosis, neoplasms, endocrine, metabolic, and chronic diseases; hereditary factors like schizophrenia; socio-pathological factors like worries, anxiety, frustration, emotional stress, tension, unhappy marriages, broken homes, poverty, industrialization, urbanization, changing family structure, population mobility, economic insecurity, cruelty, rejection, neglect. Environmental factors are environmental toxins, substance abuse, radiation, nutritional factors, mineral deficiencies, infectious diseases during prenatal, perinatal, and postnatal periods like rubella, road traffic accidents. Exposure to causal factors during the initial 5 years of life leads to an increased incidence of mental illness. This period is critical for lifelong mental health behavior and learning, even more crucial than adolescence. During early childhood, the growth and development of children are most vulnerable to external environmental stressors. A continuous, intimate, and warm relationship with the child's parents during infancy and childhood is very important. Improving the social environment is a method of primary prevention of mental illness, not secondary prevention. The levels of prevention of mental illness and measures are given below. They are primary prevention, which includes improving the social environment and the promotion of mental health awareness. Secondary prevention is early diagnosis and family based health services like casework and family counseling. Tertiary prevention measures to reduce the duration of mental illness as well as family and community stresses to prevent further breakdown and disruption. Patients with manic depressive psychosis are considered to have major mental illness. Mental health disorders are classified as major as well as minor. Major mental health disorders include schizophrenia, manic depressive psychosis, and paranoia. Major mental health disorder is psychotic or not in touch with reality. Next is minor mental health disorder, which includes neurosis like OCD, personality and character disorders. Minor mental health disorder is non-psychotic, remain in touch with reality. Dementia occurs secondary to organic causes. Employment services are not included under mental health services. Mental health services include early diagnosis and treatment, group and individual psychotherapy, mental health education, use of modern psychoactive drugs, rehabilitation, aftercare services which help drug dependent persons to adapt to regular life following treatment and rehabilitation. Next case is a 32-year-old man is brought to the casualty with a suspected drug overdose. His sister tells you that he has recently started taking a Superman drug after hearing about it from his friends. The drug is amphetamines, which is known as the Superman drug. This is because their effects include increased self confidence and endurance. However, its usage leads to tolerance and dependence. Cannabis is the most widely used illicit substance in the world. Cannabis is obtained from Cannabis sativa, Cannabis indica, and Cannabis americana. It is colloquially called marijuana. Other forms of the drug are charas or hashish and bhang. According to the National Mental Health Survey of India, tobacco is the most widely used legal addictive substance in India. It is associated with several conditions like oral cancer, lung cancer, periodontal disease, and cardiovascular disease. Alcohol is the second most substance abused in India. Ensuring equal rights to mentally ill people is not an objective of the National Mental Health Program. It was launched in 1982 with the following objectives, that is, to ensure availability and accessibility of minimum mental health care, encourage the application of mental health knowledge in general care, and to promote community participation in mental health service development. The National Mental Health Program was relaunched as the Mental Health Care Act 2017, which includes provisions for equal rights for those with mental illness. Screening is not a component of the district mental health program. It includes the following components like training of all mental health workers at the nodal institute in the state, increasing public awareness by education to reduce stigma, early detection and treatment, providing data for future planning, improvement in service and research. Activities by the DMHP for positive mental health include school mental health services, college counseling services, workplace stress management, and suicide prevention services. Establishing mobile mental health camps for the benefit of mentally ill patients is not included under the Mental Health Care Act of 2017. This act encourages the mobilization of resources to improve mental health care across the country as well as reduce stigma and improve social inclusion or support for those with mental illness. It also has provisions to improve outcomes and protect their rights. The provisions of this act include rights of person with mental illness to access health care, live without discrimination and enjoy confidentiality, advance directives to allow mentally ill people to make decisions about their treatment, decriminalizing suicide and prohibiting electroconvulsive therapy unless anesthesia is used, and procedures for admission, treatment, and discharge. Treatment includes behavioral as well as interpersonal therapy and medications. The Act also has clear instructions for the central and state mental health authorities and other mental health establishments on their endeavors. The National Suicide Prevention Strategy, that is NSPS, aims to reduce suicide mortality by 10% in India by 2030. It is a multi-sectoral approach that will involve national and international government ministries, families, communities, and educational institutes to help prevent suicide. India has a high burden of suicide. It is the leading cause of death among individuals between 15 to 29 years of age. Epidemiology: young and middle aged adults between 18 to 45 years, males more than females, daily wage earners, and people who earn less than 1 lakh per annum, individuals with family issues and illness. Hanging and poisoning were the most common methods of suicide. It accounts for more than three-fourths of all suicides. Risk factors for suicide include lack of social support and sense of isolation, the stigma associated with help-seeking behavior of mental disorders, lack of social support, domestic violence or abuse, relationship or social loss, job or financial loss, major physical illness, alcohol and other substance abuse disorders, and psychiatric illness like depression, BPD, schizophrenia, and anxiety disorders. The National Suicide Prevention Strategy is a multi-sectoral approach that will involve national and international government ministries, families and communities, and educational institutes. It aims to reduce suicidal mortality by 10% in India by 2030. It recommends REDS path for suicide prevention. What is REDS? R for reinforced leadership, partnership, and institutional capacity in the country. E for enhance the health services capacity to provide suicide prevention services. D for develop community resilience, societal support for suicide prevention, and reduce stigma against suicidal behaviors. and S for strengthen surveillance and evidence generation. Objectives are to establish effective surveillance mechanism for suicide prevention in next 3 years, to establish psychiatric OPDs that provide suicide prevention services through district mental health program within next 5 years, to integrate mental well-being curriculum in all educational institutes within the next 8 years. Next is a case. A 42-year-old male prisoner is being evaluated for aggressive tendencies and antisocial behavior. XYY genotype is often associated with aggressive tendencies, antisocial, and often criminal behavior. It is called Jacobs syndrome. XXY genotype is associated with Klinefelter syndrome. XO genotype is associated with Turner syndrome. Triple X syndrome is associated with genotype XXX. It is also called super female. The risk of developing Down syndrome in a baby born to a 45-year-old woman is 1 in 50. The risk of developing Down syndrome in a baby born to a 20-year-old woman is around 1 in 3000, and it increases with rising maternal age. It is an autosomal disorder caused by trisomy of chromosome 21. Next is examples of autosomal dominant conditions: hereditary spherocytosis, hypercholesterolemia, hypertrophic obstructive cardiomyopathy, Huntington's disease, Ehlers-Danlos syndrome, achondroplasia, von Willebrand disease, von Hippel-Lindau disease, dystrophia myotonica, osteogenesis imperfecta, otosclerosis, Marfan syndrome, multiple endocrine neoplasia, intermittent porphyria, neurofibromatosis 1 and 2, autosomal dominant polycystic kidney disease, Noonan syndrome, tuberous sclerosis, familial adenomatosis polyposis, hereditary hemorrhagic telangiectasia, Leigh-Fromany syndrome, pseudo-hypoparathyroidism. Next is examples of autosomal recessive conditions. Code is ABCDEFGHI. A for ataxia telangiectasia, albinism, alkaptonuria, autosomal recessive polycystic kidney disease. B for blood disorders like beta thalassemia and sickle cell anemia. C for cystic fibrosis, congenital adrenal hyperplasia. D for sensorineural deafness. E for emphysema, which is alpha-1 antitrypsin deficiency. F for Friedreich ataxia. G for Gaucher's disease, galactosemia, glycogen storage disease. H for homocystinuria, hemochromatosis. I for inborn errors of metabolism like phenylketonuria, lysosomal storage disease. Next is Wilson's disease, sickle cell anemia, thalassemia, spinal muscular atrophy, carcinoid syndrome, mucopolysaccharidosis except Hunter syndrome, sphingolipidosis except Fabry disease. Examples of X-linked recessive conditions are Lesch-Nyhan syndrome, Lowe syndrome, Hunter syndrome, hemophilia A and B, chronic granulomatous disease, glucose-6-phosphate deficiency disorder, Duchenne muscular dystrophy, diabetes insipidus, color blindness, agammoglobulinemia, Alport syndrome, ocular albinism, Fabry disease, Wiskott-Aldrich syndrome, Menkes disease, ornithine transcarbamylase deficiency. Next is examples of X-linked dominant conditions: Rett syndrome, rickets, Alport syndrome, which is the common inheritance pattern, type 10 Charcot-Marie tooth disease. Autosomal recessive disorders usually manifest in childhood or earlier. Heterozygotes are unaffected by the disease. When both parents are heterozygous, each offspring, that is both male and female, has a 1:4 chance of being affected. Examples of autosomal recessive disorders include several inborn errors of metabolism like phenylketonuria, cystic fibrosis, and galactosemia. Next is a case. A 6-year-old boy with recurrent hemarthrosis was found to have deficiency of factor VIII. He was adopted and his family history is unknown. The given clinical scenario is suggestive of hemophilia A. It is an X-linked recessive disorder. Hemophilia is of two types, hemophilia A and hemophilia B. Hemophilia A is due to mutations in the F8 gene leading to factor VIII deficiency. Hemophilia B is due to mutations in the F9 gene leading to factor IX deficiency. Affected children often present with prolonged bleeding after procedures like circumcision or major bleeds like intracranial hemorrhages. When the child begins to walk, bleeding into the joint, that is hemarthrosis, may occur, causing painful swellings and reddening. Lab investigations show elevated APTT with normal PT and platelet count. It is treated by the administration of factor 8 or factor 9 concentrates. Next case is a pathologist is examining the peripheral smear of a patient with anemia. The peripheral smear showed sickling of RBC, which is suggestive of sickle cell anemia. It is an autosomal recessive disorder. The prevalence is high among Africans. This disorder usually has its onset during the first year of life. Couple at risk can opt for prenatal testing and diagnosis as well. The primary goal of the Human Genome Project was to determine the sequence of nucleotide base pairs that make up human DNA and to map all genes from the human genome, that is 20,500 genes. The project was launched in 1990 and deemed complete in 2003. The Hardy-Weinberg law is related to population genetics. Population genetics is the study of the precise genetic composition of a population and various factors determining the incidence of inherited traits in them. Founder effect is a violation to this law. It is due to difference in expression of the genes in founding population. This is responsible for the difference in the distribution of disease in the population. In detail about the Hardy-Weinberg law, the Hardy-Weinberg law is related to population genetics. It is based on the principle found by G. H. Hardy and Wilhelm Weinberg. The law states that the relative frequencies of each gene allele tends to remain constant from generation to generation in the absence of other evolutionary influences. It is also called Hardy-Weinberg equilibrium or principle. It is only applicable for infinitely large static populations which randomly mate. This law fails in the following conditions like small and dynamic populations, mutations, migration, gene outflow and genetic drift, and non-random or associative mating. Positive eugenics is encouraging the breeding of those with desirable phenotypes. Negative eugenics is discouraging the breeding of those with undesirable phenotypes. Euthenics is the environmental manipulation to enable genes to express themselves. Eugenics is the science of making phenotypic improvements to humans after birth, generally to affect a problematic genetic condition. Next is a case. A young woman with family history of beta thalassemia is planning to marry her first cousin. This young woman must be advised to undergo prospective counseling. It refers to the process explaining to heterozygous individuals the risk of having affected children if they marry another heterozygous individual. It is performed prior to conception. Retrospective counseling is performed after the genetic disorder has already occurred in the first child. Next case is a 40-year-old pregnant woman is planned for amniocentesis. Amniocentesis can be done as early as 14 weeks of gestation. It refers to the examination of a sample of amniotic fluid to diagnose chromosomal disorders and some metabolic errors. It is indicated in the following cases like pregnant woman aged 35 years or above, family history of chromosomal abnormalities, metabolic errors, chromosomal translocation, and also sex-linked genetic disease. A Punnett square is a diagram used to predict the probability of a particular genotype in an offspring. It is a standard tool for genetic counselors. The risk of genetic disease in consanguineous marriage between first cousins is 4 to 8%. The risk of genetic disease in non-consanguineous marriage is 2 to 4%. Next topic is disaster management. A disaster is defined as any occurrence that causes damage, ecological disruption, loss of human life, or deterioration of health and health services. It usually requires an extraordinary response from outside the affected community or area. A hazard is any phenomenon that has the potential to cause disruption or damage to people and their environment. Hydrological natural disasters cause the most deaths. The Disaster Information Management System of DES Ventar classifies natural disasters into 5 major categories. They are geophysical, hydrological, meteorological, climatological, and biological. Geophysical include earthquakes, tsunamis, and volcano eruptions. Meteorological includes cyclones, tornadoes, extreme temperatures, sandstorms, blizzards, etc. Hydrological includes floods, debris flow, and landslides. Climatological include drought, forest wildfire, glacial lake outburst, etc. Biological include epidemics and insect infestations. The correct order for disaster impact is response, rehabilitation, mitigation, prevention, and preparedness. Response and rehabilitation is present in the recovery phase after disaster. Mitigation, prevention, and preparedness is present in the risk reduction phase before disaster. Disaster management includes three aspects. They are disaster impact and response, which involves immediate management of mass casualties as follows, like search, rescue and first aid, field care, triage, tagging, and identification of dead. Next is rehabilitation or recovery. It involves the restoration of the pre-disaster conditions by taking steps such as water supply, vector control, food safety, basic sanitation, and personal hygiene. Next is mitigation. It measures designed either to prevent hazards from causing disaster or to reduce the effect of the disaster. This also includes preparedness for any impending disasters or in disaster prone areas. Gastroenteritis is the most common reported disease after disaster. It occurs due to contamination of water supply, damage to the sewerage system, overcrowding and poor sanitation. Therefore, supply of safe drinking water and proper disposal of excreta are the most practical and effective strategies of disease prevention in the post-disaster period. Leishmaniasis is not commonly seen in the post-disaster period. Diseases that are commonly seen in the post-disaster phase are gastroenteritis, which is most common, acute respiratory infections, leptospirosis, rickettsiosis, rabies, and equine encephalitis. Next is a case. A district in Andhra Pradesh reported severe drought. Vitamin A deficiency is the most common deficiency in areas of famines and droughts. It leads to xerophthalmia and blindness. Next case is, following a drought in Bihar, the government launched an immediate mass vaccination program. Measles vaccination is recommended for infants and children immediately following a disaster. This should be given along with vitamin A supplementation, as measles can exacerbate vitamin A deficiency. The vaccination of infants and children against measles is one of the most important public health response measures during a humanitarian crisis when less than 90% of the children or an unknown percentage have already been vaccinated against measles. Measles and polio vaccines are recommended immediately after an emergency. Tetanus vaccine is recommended in the early stages and post-emergency stage. The WHO does not recommend typhoid, cholera, and rabies vaccine for mass vaccination after disaster. However, high-risk populations are recommended to take the cholera vaccine. The rabies vaccine is given only for post-exposure prophylaxis. Next case is, you are a field doctor at the site of an earthquake. You assist in rapidly classifying the injured on the basis of the likelihood of their survival and need for intervention. The process of rapidly classifying the injured in a disaster on the basis of severity of injury and likelihood of survival with prompt medical intervention is called triage. It is carried out at the site of disaster. Tagging is the identification of patients in a disaster with tags stating their name, age, place of origin, triage category, diagnosis, and initial treatment. Triage system consists of four color codes: red, which is high priority; yellow, which is medium priority; green, which is low priority; black is least priority. If the color code is red for triage system, that means it need immediate resuscitation or surgery in the next 6 hours or transfer, may survive if timely medical intervention can be given. Example is tension pneumothorax, airway obstruction, hemothorax, cardiac tamponade, acute circulatory arrest, major intra-abdominal bleed, etc. Next is yellow triage. It is the possible resuscitation or surgery in the next 24 hours, likely to survive if prompt treatment is given. Example, compound fractures, degloving injuries, pelvic fracture, spinal injuries, moderate head injury. Next is green, which is of low priority. Here ambulatory patients or minor illness is seen, likely to survive if treatment is slightly delayed. Examples, simple fractures, minor lacerations, etc. Next is black. it is of least priority. Here we can see dead or moribund patients. Examples: severe brain injury, major damage or disruption to chest wall and abdominal structures. In triage, green signifies low priority or ambulatory patients and those with minor illness. An internationally accepted 4-color coded system with red having the highest priority is used commonly here. Reverse triage is a situation where the less injured are treated earlier than the ones that are injured more. This is used in wars and military settings where soldiers may need to return to the field of battle soon after treatment. It is also done when there is a scarcity of medical resources after a disaster. The surge capacity of hospitals is increased to accommodate for the natural disaster by discharging non-emergent existing patients. This enables hospitals to allow for an acute increase in incoming patients. Triage is done during disaster management to ensure treatment of casualties, which is done properly. Moribund patients receives the lowest priority. This is because despite paying quite a lot of attention, the benefit is still questionable. The advisable level of residual chlorine in water bodies after disaster is zero point 0.7 to zero point 0.9 mg per liter. Chlorine is a disinfectant that is added to water bodies. In normal conditions, water should have free residual chlorine of zero point 0.2 to zero point 0.5 mg per liter. However, during a disaster, there is an increased risk of fecal contamination of water sources from the sewage systems. Therefore, it is necessary to increase FRC, that is free residual chlorine, to zero point 0.7 to zero point 0.9 mg per liter. The gas responsible for the Bhopal gas tragedy, which occurred on 3rd December 1984 at the Union Carbide pesticide plant, was methyl isocyanate. Chernobyl nuclear explosion occurred on 26 April 1986 in the Soviet Union, caused the release of iodine 131, cesium 134, cesium 137 and strontium 90 and other isotopes into the atmosphere. The Ministry of Home Affairs is the nodal ministry for disaster management at the center, except for dealing with droughts, which are under the purview of the Ministry of Agriculture. Other parts of the Indian government involved in disaster management are the Emergency Medical Relief Wing under the Ministry of Health and Family Welfare. The Indian Meteorological Department plays a role in mitigation of disaster and its preparedness. The District Disaster Management Authority is the nodal center for disaster management. It is chaired by either the District Collector, District Magistrate, or the Deputy Commissioner. The Chief Medical Officer of the district is a part of this authority. The NIDM is involved in the mitigation and management of disasters in India. The NIDM, that is National Institute of Disaster Management, is under the Ministry of Home Affairs of India. Its president is the Union Home Minister. National Institute of Disaster Management is a premier institute for training and capacity development programs for managing natural disasters in India on a national as well as regional basis. National Disaster Management Authority is an apex body of the Government of India with a mandate to lay down policies for disaster management. It is chaired by the Prime Minister of India. Next topic is nutrition and health. According to 2020 guidelines of the National Institute of Nutrition, the weight of the reference Indian adult woman is 55 kg and adult male is 65 kg. Age for Indian adult man is 19 to 39 years. Age for Indian adult woman is 19 to 39 years. Height according to reference Indian adult man is 1.73 meter and in adult woman it is 1.61 meter. BMI for Indian adult man is 21.7 and in adult woman is 21.2. The energy required by an adult for basal metabolism is 1 kilocalorie per hour per kg of body weight. The energy requirement of a pregnant woman who leads a moderately active lifestyle is around 2500 kilocalorie per day. An adult woman leading a moderately active lifestyle requires 2130 kilocalorie daily and an additional 350 kilocalorie is needed in pregnancy. Hence, the total requirement for a moderately working pregnant woman is 2480 kilocalorie per day, approximately 2500 kilocalorie per day. RDA or recommended dietary allowance is the average daily dietary intake that is sufficient to meet the requirements of almost all individuals in a group. EAR or estimated average requirement is a nutrient intake value that is estimated to meet the requirements of half the individuals in a group. The estimated average requirement for an elderly male more than 60 years is 1700 kilocalorie per day, and for an elderly female more than 60 years it is 1500 kilocalorie per day. There is no RDA for energy. The EAR is equivalent to estimated energy requirement, that is, estimated average requirement is equal to estimated energy requirement. Next case is a nutritionist is preparing a meal plan for a healthy 32-year-old man. The proportion of nutrients in the diet must be carbohydrates more than fats more than proteins. While constructing a balanced diet, nutrient requirements must be calculated in the following sequence. Protein requirements is 10 to 15% of daily energy intake. Fat requirement is 15 to 30% of daily energy intake. Carbohydrate is remaining food energy. High quality protein refers to proteins containing all the essential amino acids. According to FAO or WHO 2007 guidelines, the recommended high quality protein intake for adult men and women is 0.83 gram per kilogram per day. Recommended high quality protein intake by FAO or WHO is in between 1 to 5 years, required protein is 0.94 gram per kg per day. In between 6 to 10 years, protein required is 0.91 gram per kg per day. In adolescent males, protein requirement is 0.88. In adolescent female, protein requirement is 0.86. In adult man or woman, protein requirement is 0.83 gram per kg per day. However, the mixed Indian diet does not meet the requirement for high quality protein. Hence, the protein requirement in Indian adults, including men and women, is 1 gram per kg per day of mixed Indian diet protein according to the ICMR 2010 guidelines. Dietary protein energy percentage is less than 4%, which indicates inadequate protein intake. The protein energy percentage indicates that the proportion of total energy in the diet is derived from proteins. Protein energy percentage equal to energy from protein divided by total energy in the diet into 100. Some of the food items and their protein energy percentage are fish, protein energy percentage is 80, cow milk it is 20, dal it is 24, rice it is 8, potato it is 6, banana it is 4, and in tapioca it is 2. Digestible indispensable amino acid score, that is DIAAS. It is the best indicator for protein quality. DIAAS reflects the digestibility of individual amino acids in the protein. Total protein digestibility does not always reflect the digestibility of individual dietary indispensable amino acids. Hence, DIAAS, that is digestible indispensable amino acid score, has replaced the protein digestibility corrected amino acid score as the preferred index for the evaluation of protein quality. Next is assessment of protein. Protein quality is assessed by comparing with reference protein, that is egg protein, which includes amino acid score as well as net protein utilization. Amino acid score is a measure of the concentration of each essential amino acid in the protein to be tested, expressed as a percentage of that amino acid in the reference protein. Digestible indispensable amino acid score is the best indicator of the protein quality. Next is net protein utilization. It is a product of digestibility coefficient and biological value divided by 100. Protein quantity, it is assessed by protein energy ratio. Net protein utilization of various food items in the descending order are egg 100, meat 80, milk 75, rice 65, soya 61. Low net protein utilization indicates a high protein requirement. The net protein utilization of Indian diet is usually between 50 and 80. Next case is a farmer has been consuming a maize-rich diet for many years. His diet would be lacking lysine and tryptophan as maize is deficient in these amino acids. In cereals, amino acid deficient is lysine. In maize, lysine and tryptophan is deficient. In wheat, lysine and threonine is deficient. In pulses, which is also known as poor man's meat, methionine and cysteine is deficient. Safflower oil contains the highest content of essential fatty acids. Linoleic acid is the most important essential fatty acid. In safflower oil, percentage content of linoleic acid is 75. In corn oil, percentage content of linoleic acid is 50. In sunflower oil, percentage content of linoleic acid is 62. In soybean oil, percentage content of linoleic acid is 53. Milk is also rich in linoleic acid and oleic acid. Next case is you are counseling a diabetic patient to consume foods with low glycemic index. The patient should be advised to eat whole grains since it has low glycemic index. Glycemic index is a number representing the relative ability of a carbohydrate food to increase the level of glucose in the blood. It is calculated by comparing the test carbohydrate to the standard, that is glucose or white bread. This measures has practical use in the management of diabetes and obesity. Low GI foods include mostly fruits and vegetables, whole grains, pasta foods, beans and lentils. Moderate glycemic index foods are sucrose, basmati rice and brown rice. High glycemic index foods are cornflakes, baked potatoes, white bread, potatoes, watermelon and sweet corn, candies and syrupy foods. The renal feed of a patient suffering from end-stage renal disease stage 5 should be low volume and high calories. Dietary factors may have an effect on the progression of kidney disease and its complications. A low volume feed is preferred in order to avoid sodium and volume overload, hyperkalemia, hyperphosphatemia, accumulation of toxic metabolites of protein degradation. A high calorie feed is preferred in order to combat the patient's risk of malnutrition and wasting seen in end-stage renal disease. Indicators for body fat are body weight, body mass index, Ponderal index, Corpulence index, Broca's index, Lorentz formula, skin fold thickness, waist circumference and waist hip ratio, total body water, total body potassium and body density. In the Indian or Asian population, a BMI of 23 to 24.99 is classified as overweight. However, in the global population, a BMI of 25 to 29.99 is considered overweight. A body mass index of 13 or less is considered lethal in men. However, females can survive even at a lower BMI up to 11. Waterloo's classification makes use of height for age and weight for height to assess the nutritional status of children. Height for age indicates stunting and denotes the chronicity of malnutrition. On the other hand, weight for height indicates wasting and denotes the severity of malnutrition. The Gomez classification uses weight for age as an indicator of nutritional status. The disadvantage is that it is difficult to determine whether the low weight is due to an acute attack of malnutrition or chronic undernutrition. The Codex Alimentarius Commission formulates food standards for the international market. It is the principal organ of the FAO or WHO Food Standards Program. The ISI standard, that is Indian Standard Institute, and AGMARC are the Indian food standards. They are based on the standards of Codex Alimentarius. The PFA Act, that is Prevention of Food Adulteration Act, was introduced to provide protection from adulteration or contamination of food. Vanaspati is fortified with 2500 international unit of vitamin A and 175 international unit of vitamin D. 1 gram of double fortified salt contains 40 mcg iodine and 1 milligram of iron. Dehydration contributes to a significant loss in the beta-carotene levels in food. Processes that do not affect beta-carotene levels in the food are boiling, canning and freezing. Next is a case. In order to effectively prevent endemic goiter, the recommended iodine content in salt at the consumer level is 15 ppm. The iodization of salt is used as a prophylactic measure against endemic goiter. In India, the level of iodization is fixed under the Prevention of Food Adulteration Act. The recommended level of iodine content in salt is 15 ppm at the consumer level and 30 ppm at the production level. Next case is in a milk factory, the milk is heated at 63 degrees Celsius for 30 minutes and then cooled quickly to less than 13 degrees Celsius. The method described above is the Holder method of pasteurization. Coxella burnetii can survive this method since it is highly heat resistant. It causes Q fever. The various methods of pasteurization are Holder or Watt method, which consists of 63 to 66 degrees Celsius for 30 minutes. Next is HTST method, that is high temperature short time. Here the temperature is 72 degrees Celsius for 15 seconds. Next is UHT method, that is ultra high temperature method. Here 125 degrees Celsius for a few seconds. These are the various methods of pasteurization. Methylene blue reduction test is not used to check the efficiency of pasteurization. Methylene blue reduction test is used for grading raw milk quality prior to pasteurization. The following tests are used to check the efficiency of pasteurization. They are phosphatase test, standard plate count, and coliform count. Next case is, in a rice processing factory, paddy is soaked in hot water. After this, the water is drained and the paddy is steamed and dried. The procedure mentioned above is parboiling. It hardens the rice grains. Parboiling is the process of partial cooking of rice in steam. It is done by the hot soaking process that was initially developed by the Central Food Technological Research Institute, Mysore. The advantages of parboiling are: preserves nutritive quality by driving the vitamins and minerals into the endosperm, and hardens the grains and makes them insect resistant. Next case is, a 35-year-old man presented with gradually progressive muscle weakness and leg spasm for 2 months. He says that he had been consuming an inexpensive dal resembling red gram for the past 2 years. Pure motoparesis was seen on examination. The given clinical features are suggestive of neurolathyrism. It can be prevented and treated by the administration of vitamin C at doses of 500 to 1000 mg. Lathyrism is a paralyzing disease of humans and animals. It is due to the consumption of kesari dal or Lathyrus sativus. When the husk is removed, it looks similar to red gram or Bengal gram. BOAA, that is beta oxalyl aminoalanine, is the toxic compound causing this disease. It is water soluble and can be removed by the following methods, like parboiling, which is used for large scale detoxification, overnight soaking in lime water followed by boiling, and other method is soaking pulses in hot water and discarding the water. Next is about food adulteration diseases. In dal, the adulterant is kesari dal, that is Lathyrus sativus. Toxin is BOAA. Disease here is lathyrism. In oil, the adulterant is Argemone mexicana oil. Toxin is sanguinarine. Disease is epidemic dropsy. In millet, adulterant is Crotalaria seeds or Junjunia. Toxin is pyrrolizidine alkaloids, which is hepatotoxic. Disease is endemic ascites. In bajra wheat, the adulterant is Claviceps purpurea. Toxin is clavin alkaloids. Disease is ergotism. Next case is, a 45-year-old woman is being evaluated for sudden onset of hypersecretory glaucoma, diarrhea, and cardiac failure. Further probing reveals that she had been purchasing groceries from a dealer who was recently arrested for food adulteration. This clinical scenario is suggestive of epidemic dropsy. It is caused by the toxic compound sanguinarine, which is present in argemone oil. It is commonly used as an adulterant in mustard oil. Epidemic dropsy results in sudden onset of swelling of lower limbs, diarrhea, and breathlessness. Some patients may develop hypersecretory glaucoma. It can lead to death due to cardiac failure. Adulteration with argemone oil can be detected by the following test, that is nitric acid test as well as paper chromatography, which is the most sensitive test. Next is a case. A patient presented with rough, dry skin suggestive of phrenoderma. It is treated by supplementation of safflower oil, which is rich in essential fatty acids and vitamin B complex. Phrenoderma or toad skin is a type of follicular hyperkeratosis. It is caused by a deficiency of vitamin A, B, C, E, and essential fatty acids. Gingerly seeds or sesame seeds have the highest content of thiamine. The thiamine content in various foods in decreasing order are as follows: gingerly seeds, groundnut, Bengal gram, whole wheat, raw rice. Thiamine is lost from rice during the process of milling. As it is a water-soluble vitamin, washing and cooking rice cause further losses. Hence, it is advisable to avoid highly polished rice and eat parboiled or undermilled rice. Next case is, a patient presented with loose stools and skin rashes over the sun-exposed areas. Diet history revealed that the patient had been consuming a jowar-rich diet since childhood. This clinical scenario is suggestive of pellagra. It is caused by excess of leucine in jowar. Excess of leucine in jowar, that is sorghum, and maize interferes with the conversion of tryptophan to niacin, causing pellagra. It presents with the following features like diarrhea, dermatitis, and dementia. People consuming jowar also have a higher risk of developing genu valgum and osteoporosis due to greater retention of ingested fluoride. Next, talking about fat soluble vitamins. Fat soluble vitamins are vitamin A, vitamin D, vitamin E, and vitamin K. Now about vitamin A, active form of vitamin A is retinol, retinal, and retinoic acid. Deficiency of vitamin A can cause night blindness, xerophthalmia, acne, psoriasis, impaired immunity. If there is vitamin A toxicity, it affects lysosomes. In case of acute vitamin A toxicity, it can cause pseudotumor cerebri and also exfoliative dermatitis. In chronic cases, we can see fractures. Next is vitamin D. Active form of vitamin D is 1,25-dihydrocholecalciferol. Vitamin D deficiency in children is rickets and in adults it is known as osteomalacia. Vitamin D toxicity causes calcinosis. Next about vitamin E. Active form of vitamin E is alpha tocopherol. Deficiency of vitamin E can cause hemolytic anemia, axonal degeneration, spinocerebellar ataxia. Vitamin E toxicity causes reduced platelet aggregation and it interferes with vitamin K. Next about vitamin K, the active form of vitamin K is menadione, menoquinone and phylloquinone. Vitamin K deficiency causes elevated prothrombin time and bleeding and also hemorrhagic disease of newborn. Vitamin K toxicity can cause hemolysis, hyperbilirubinemia and kernicterus. The required dietary allowance of vitamin A in children is in between 1 to 9 years it is 390 to 630 microgram. In between 10 to 18 years it is 770 to 1000 microgram. In males the RDA of vitamin A is 1000 microgram. In adult female RDA of vitamin A is 840 microgram. During pregnancy it is 900 microgram. During lactation it is 950 microgram. Required dietary allowance for children of vitamin D is for less than 1 year it is 400 IU and for more than 1 year it is 600 IU. In males it is 600 IU. In adult females it is 600 IU. In pregnancy it is 600 IU and in lactation it is 600 IU. Required dietary allowance of vitamin E in children is 5 to 8 milligram. In males it is 10 milligram. In adult females it is 8 milligram. In pregnant females 10 milligram. In lactation 12 milligram. Required dietary allowance of vitamin K in children less than 1 year it is 2 to 3 microgram. In children generally 30 to 50 microgram more than 1 year. In males it is 55 microgram and in females it is 55 microgram. The recommended vitamin A dosage for a 2-year-old child with keratomalacia is 2 lakh IU given immediately, followed by the same age specific dose 24 hours later and after 2 weeks. Vitamin A supplementation for 6 to 11 months age group is 1 lakh IU orally. It is given once. Vitamin A supplementation in between 1 to 5 year age group dose is 2 lakh IU orally given every 4 to 6 months. A total dose of 17 lakh IU given as per the following schedule is 1 lakh IU given with measles vaccine at 9 months, 2 lakh IU given with DPT booster at 15 to 18 months and 2 lakh IU is given every 6 months till 5 years of age. Treatment of vitamin A deficiency in age group less than 6 months it is 50,000 IU. In between 6 to 12 months we should give 1 lakh IU. In age group more than 1 year we should give 2 lakh IU. Route of administration is oral in the form of retinyl palmitate. The term xerophthalmia is reserved to cover all the ocular manifestations of vitamin A deficiency. Stage XN is night blindness, pathophysiology is lack of rhodopsin. Stage X1A is conjunctival cirrhosis, pathophysiology is conjunctival epithelial alteration and loss of goblet cells. Stage X1b is Bitot spot. Pathophysiology is conjunctival keratinization and plaque formation. Stage X2 is corneal cirrhosis. Pathophysiology is corneal epithelial alteration. Stage X3a is corneal ulceration or keratomalacia affecting less than one-third of the corneal surface. Pathophysiology is liquefaction of corneal stroma. Stage X3b is corneal ulceration or keratomalacia affecting more than one-third of corneal surface. Stage XS is corneal scar. Stage XF is xerothalmic fundus. Pathophysiology is degeneration of the retinal pigment epithelium. The first symptom of xerophthalmia is nyctalopia. The first sign of xerophthalmia is conjunctival cirrhosis. The pathognomic feature of xerophthalmia is appearance of Bitot spot. Vitamin A deficiency is considered a public health problem if the prevalence rate of corneal cirrhosis among children between 6 months to 6 years, which is a high risk category, is more than 0.01%. According to National Institute of Nutrition 2020 guidelines, the recommended dietary allowance for dietary iodine in lactating women in India is 280 microgram per day. According to WHO guidelines, the RDA during both pregnancy and lactation for dietary iodine is 250 microgram. Median urinary iodine excretion level less than 100 microgram per liter in non-pregnant population indicates insufficient iodine intake. Urinary excretion of iodine is used by the WHO for surveillance and epidemiological studies to classify countries according to the level of iodine deficiency. It is an effective indicator of national programs against iodine deficiency. Neonatal hypothyroidism is a sensitive indicator of environmental iodine deficiency. It is also an effective indicator to monitor the impact of a program. Serum T4 level is a more sensitive indicator of thyroid insufficiency in the population than T3. Determination of iodine in salt is a part of quality control of the product. The UNICEF uses MBI kits to rapidly assess the levels of iodine in salt. The recommended dietary allowance of folic acid in a 5-year child is 150 microgram, adult male is 300 microgram, adult female it is 220 microgram, pregnancy it is 570 microgram, lactation it is 330 microgram. Recommended intake per day for iron in adult male is 19 mg, adult female is 29 mg, in pregnancy it is 27 mg, in lactation it is 23 mg. Recommended intake per day for calcium in adult male is 1000 mg, in adult female it is 1000 mg, in pregnancy it is 1000 mg, in lactation it is 1200 mg, in elderly it is 1200 mg. Recommended intake per day for phosphorus is 1000 mg, for sodium it is 2000 mg, for potassium it is 3500 mg, for copper it is 2 mg, for manganese it is 4 mg, for chromium it is 50 microgram, for selenium it is 40 microgram. Under the Anemia Mukt Bharat program, a 6-year-old child should be given 45 mg elemental iron plus 400 microgram folic acid, that is 1 iron and folic acid tablet weekly. The tablet is sugar coated and pink in color. In women of reproductive age group, if it is non-pregnant or non-lactating, in the age group in between 20 to 49 years, under Mission Parivar Vikas, 1 iron and folic acid tablet of 60 mg elemental iron plus 500 microgram folic acid. It is sugar coated. It should be given weekly and the tablet is red in color. For pregnant women and lactating mothers of 0 to 6 months child, 1 iron and folic acid tablet starting from the 4th month of pregnancy is continued throughout pregnancy. Minimum 180 days she should have it. It should also be continued for 180 days postpartum. It is given as 60 mg elemental iron plus 500 microgram folic acid. It is given daily. It is a sugar coated and red tablet. Prophylaxis with iron should be withheld in case of acute illness like fever, diarrhea, pneumonia, etc. and in a known case of thalassemia major or history of repeated blood transfusion. In case of children with severe acute malnutrition, iron and folic acid supplementation should be continued as per the SAM management protocol. All women in the reproductive age group in the preconception period and up to the first trimester of pregnancy are advised to have 400 microgram of folic acid tablets daily to reduce the incidence of neural tube defect in the fetus. A premenopausal woman requires 1000 mg calcium on a daily basis. Individuals with fluoride intake more than 10 mg per liter are at risk of developing crippling fluorosis. Complications of fluorosis seen with corresponding levels of fluoride intake are dental fluorosis, which consists of 1.5 mg per liter, skeletal fluorosis, which consists of 3 to 6 mg per liter, crippling fluorosis, there will be more than 10 mg per liter of fluoride. Genovalgum may occur in people who consume jowar, that is sorghum, as it promotes greater retention of ingested fluoride. The Nalgonda technique is used for the defluoridation of water bodies. It involves the addition of lime and alum followed by flocculation, sedimentation and filtration. Water requirement in an adult male is 32 to 58 milliliter per kg. Water requirement in adult female is 27 to 52 milliliter per kg. In children, water requirement is more than 60 milliliter per kg. In adolescent, water requirement is 40 to 60 milliliter per kg. In pregnant woman, water requirement is 2.1 to 3.2 liters per day. In elderly, for sedentary people, 33 milliliter per kg water requirement is needed, and in moderately active elderly people, 38 milliliter per kg water requirement is needed. According to WHO guidelines, for a 12-year-old girl, the adequate daily intake of water is 2.1 liters. For a 12-year-old boy, it is 2.4 liters. Next case is a 45-year-old man visits your OPD for a general health checkup. His wife informs that he drinks only 4 to 5 glasses of water a day. The daily adequate intake of water that you advise him to take according to WHO guideline is 3.7 liters. According to WHO guidelines, for an adult male, the daily adequate intake of water is 3.7 liters. For an adult female, it is 2.7 liters. The normal daily requirement of magnesium in adult is 400 mg per day. The following are the approximate daily requirements of some electrolytes in adults. They are magnesium 400 mg per day, calcium 1000 to 1200 mg per day, potassium 3500 mg per day, sodium 1.2 to 1.5 grams per day, that is up to 2 gram per day. Next topic is communication for health education. The correct order for the process of communication is sender, message, channel, receiver, and feed. The sender or communicator is the originator of the message. A message is the information which the communicator transmits to his audience. Channel is the media of communication between the sender and the receiver. Example, interpersonal communication, mass media, traditional or folk media. The audience who receives, understands, and acts upon the message is called the receiver. Feedback is the reaction to the message which flows from the receiver to the sender. Workshop is an example of Socratic type of communication. In detail about didactic communication, it is a one-way communication. Knowledge is imposed and learning is authoritative. No audience participation, does not influence human behavior. Feedback is absent. In detail about the Socratic communication, it is a two-way communication. Learning is active and democratic. Audience shares opinions, ideas and questions. Influences human behavior. Feedback is present. Examples of didactic communication include lectures, demonstrations, television, radio, magazines, newspapers. A panel discussion is an example of Socratic type of communication. Examples of Socratic communication include symposium, panel discussions, workshops. The advantage of mass media includes that it has increased influence across all educational levels, especially in above average educational level. Mass media includes TV, newspaper, radio, etc. Advantages are it reaches people even in the most remote areas. It gets public attention. It has increased influence across all educational levels, especially in above average educational level. It gives greater support for concentrated programs. Disadvantages are one-way communication, impersonal method and no face-to-face contact. Mass media alone is inadequate in changing human behavior. Community participation is not a function of health communication. The functions of health communication are information, education, motivation, persuasion, counseling, raising morals, health development, organization. Methods of health communication include individual approach, which consists of personal contact, home visit, and personal letters. Next is group approach. It consists of lectures, demonstrations, and discussion methods like group discussions, panel discussion, symposium, workshops, conferences, seminars, and role play. Next is mass approach. It consists of TV, radio, newspaper, printed material, direct mailing, posters, health museums, health exhibitions, folk method, and internet. Socio-environmental approach is not an approach to health education. There are four approaches to health education. These are regulatory approach, service approach, health education approach, and primary healthcare approach. In detail about regulatory approach, the external control or laws placed on people by the government is regulatory approach. Example, Child Marriage Act, no smoking in public places, helmet law. Next is service approach. Here government aims at providing health services to the people at their doorsteps. Its drawback is that people will not accept a service even if it is offered free of cost unless it is based on their felt needs. Example, government provided latrines free of cost, yet people did not use them because its need was not felt. Next is health education approach, which creates awareness of health needs and problems. Awareness leads to motivation, which includes the stage of interest, evaluation, and decision making. It is followed by acceptance of the new idea, which becomes part of his existing values, known as internalization. Example, adoption of ORS for diarrhea. Next is primary healthcare approach. Here the delivery of health services with the active involvement of people is done. Principles of community participation and intersectoral coordination are stressed here. Its objective is to help individuals become self-reliant in health matters. Example, people receive guidance from healthcare providers like Rogi Kalyana Samiti or Mahila Arogya Samiti. Internalization belongs to the motivation model. There are three models of health education. They are medical model, motivation model, and social intervention model. Medical model is there is transfer of proven medical information into education. It does not bridge the gap between knowledge and behavior. Next is motivation model. It creates awareness of the health needs and problems. Awareness leads to motivation, which includes stages of interest, evaluation, and decision making. It is followed by acceptance of the new idea, which becomes part of his existing values, known as internalization. Next is social intervention model. It focuses on changing the social environment, which subsequently shapes the behavior of individual and the community. Principles of health education include participation, learning by doing, setting an example, good human relations, feedback, credibility, leaders, interest, comprehension, known to unknown, motivation, reinforcement. Known to unknown means to start where the people are and with what they understand and then proceed to new knowledge. Health education appeals to people's reason. Health propaganda appeals to people's emotions. In detail about health education, knowledge and skills are actively acquired in health education. Primitive desire is disciplined. Action of health education is reflective behavior, trains people to use judgment before acting. Emotion of health education is it does not appeal to emotion but appeals to reason. Process is behavior centered in health education. In detail about health propaganda, knowledge is instilled in the mind, primitive desire is aroused, action is reflexive behavior which aims at impulsive action, emotion of health propaganda is it appeals to emotion, process of health propaganda is information centered. Individual approach is the preferred counseling method for HIV pre and post testing. This approach will equip the individual and family to deal with the situation more effectively. Flannel graphs, exhibits, and flipcharts belong to the chalk and talk method of group communication in which the chalk is the visual component. It is also known as lectures. Flannel graphs, flipcharts, exhibits, films, and charts come under this method. Disadvantage of lectures are minimum interaction, do not stimulate thinking or problem solving, comprehension is dependent on the individual, do not influence behavior directly. Next case is a group discussion was conducted among villagers to assess their knowledge on personal hygiene. A group discussion means it discusses one topic on its agenda. Group discussion is an aggregation of people interacting in a face-to-face manner. Exchange of ideas, knowledge, and opinions is done by participants which influence a change in their attitudes. It usually involves 6 to 12 people with a group leader who guides the conversation, giving equal opportunity to everyone to voice themselves. In a group discussion, everyone must speak and be open to criticism without interrupting others. A limitation to this form of health education is that not everyone is open to speaking in public. There is also a high possibility of diversion of the topic of discussion when many people are involved. A moderator is required to regulate the panel discussion. In a panel discussion, 4 to 8 experts have a discussion on a topic in front of an audience. No speeches or order is set beforehand. The audience is invited to take part after the panelists speak and ask questions. A workshop is a series of meetings with an emphasis on individual work within the group. External consultants or experts may be involved. A symposium is a series of lectures on selected subject by experts after which the audience is allowed to ask questions. That means no discussion is involved in symposium. Role play is the dramatization of social situations for health education by those taking part in it. Seminars are similar to conferences and incorporate a variety of methods like speeches, discussions for health education, which may last for half a day to week. A workshop is a series of meetings with an emphasis on individual work within the group using external consultants or experts. It helps increase individual efficiency as a professional worker. Flannel graphs, podcast, and tape recorders are not combined audiovisual aids. Flannel graph is a rough flannel fixed over a wooden board used for displaying pictures, cutouts, etc. It is only a visual aid. Podcast and tape recorders are auditory aids. Audiovisual aids are classified into 3 groups. They are auditory aids like radio, tape recorders, and podcast. Visual aids like chalkboards, flannel graphs, charts, posters, slides. Combined AV aids like cinema, television, slide tape combination. Next case is a norovirus outbreak occurs in an urban slum where you are posted as PHC medical officer. The best method to teach an urban slum about ORS is by demonstrations. Demonstration is a carefully prepared presentation on how to perform a certain task or skill or a procedure. It shows the step-by-step process of a task. It arouses interest and insights learning by doing and seeing is believing philosophies. Delphi method is a systematic interactive forecasting method which is used to obtain a consensus forecast among a large number of people. It determines the degree of agreement on a topic. This can help in setting priorities or selecting alternatives in planning. This method uses questionnaires which are answered by experts in 2 or more rounds. The philosophy of total communication is used in the education of hearing impaired children. It requires the incorporation of oral, and manual modes of communication for effective communication with and among hearing impaired people. The gather approach is mainly used for counseling, like in contraceptive counseling, wherein a person is helped to make a decision about health. Gather stands for G for greet, A for ask, T for tell options or give answers, H for help in making choices, E for explain everything about the decision, R for return for follow up. Spike's protocol is for breaking bad news. Each letter represents a phase in the 6-step sequence. Spike's protocol, that is S for setting, P for perception, I for invitation or information, K for knowledge, E for empathy, S for summarizing or strategizing. Key components of the Spike strategy include demonstrating empathy, acknowledging and validating the patient's feelings, exploring the patient's understanding and acceptance of the bad news, providing information about possible interventions.